Hello, everyone. Welcome to this session on important policy lessons in building collective responses against the COVID-19 from territories in the Western Pacific region. We have got 5 speakers today, and I'll introduce them as they come up. So our first speaker will be Professor E.K. Yeo. So the important aim of this session is to provide valuable insights for other countries in the ongoing battle against the pandemic and contribute the knowledge to the field of health system research in strengthening pandemic responses. I'm Chi Tian Hong from the Chinese University of Hong Kong, and currently my interest, I'm still holding research funds in looking into the mode of spread of the COVID virus. So our first speaker today and the chair of this session will be Professor E.K. Yeo, also from the Center of Health Systems and Policy Research, the Chinese University of Hong Kong. Professor Yeo has lots of experience and interest in applying health systems thinking and studying how complex components of health systems can impact on our performance. So the tips on using the platform, if you see on your right, there will be a support chat. So you've got some problems, you can type into the support chat. On the right-hand side, when you want to post questions, please input the questions into the live Q&A. Okay. So with that, can I hand over the session to Professor E.K. Yeo to give the first talk?
Okay. Good afternoon, everyone. It's a great pleasure to be and privilege to be part of this important symposium. Today, what we're doing is among these 6 jurisdictions in the West Pacific region to look at some of the important lessons learned and the role of health system stewardship and cross-sectoral collaboration in pandemic responses. And obviously, this is very important for pandemic responses. And the speakers, the participants here and researchers, collaborators, will be covering the different facets of health system stewardship, which is important in pandemic control. So I won't cover that, repeat that. Yeah. So as Professor T. Hong said, these are the government response measures to COVID-19, the key lessons learned. And we are part of the social science research group under WHO. This is a subgroup of this working group on particularly looking at health systems impact. And the presenters are part of the group that we're working together. Right? So the aim is to examine key government containment, control, and mitigation policies and measures. And importantly, a mechanism for policy learning and insights where contextual issues can inform application to other jurisdictions. So this is an important methodology for being able to generate lessons from individual countries. So the design of study is a multiple case study of the 6 jurisdictions, and the study period is in 2 sequential periods. This report deals with the earliest stage of the pandemic from the 1st of January to 31st of May. We are updating the experiences from the 1st of June to the 31st of October, but this will not be part of the presentation today. Right? So in terms of our key areas of study, we're using a conceptual framework taking reference to the WHO's critical preparedness, readiness, and response actions for COVID-19, looking at surveillance and risk assessment, case management strategies, emergency response, case finding, quarantine, border controls, risk communications, participation of the public, social distancing, and social economic mitigation, right? So the methodology, is first look at the literature review. We did also analysis of public data sources. Then my colleagues, which are experts from the jurisdictions, to provide data and information on the key areas of study. And when the information is verified, we collated information, presented, analyzed in a collaborative learning approach. So it's really then a comparative study between the 6 jurisdictions, and then look at triangulation of various data sources and synthesis of results to generate the key lessons and challenges learned in response actions. Right? So very quickly on our findings, which will be covered in depth by individual members of the team. We first look at ongoing surveillance, which is important, as a tool for early detection and risk assessment to facilitate rapid response action. So this is important because if you don't have a good surveillance systems, the infection may disseminate very quickly before you know it. And of course, this was very evident in many of the European countries and in the Americas, where by the time they realized there was an outbreak, the infection had really disseminated widely into the community. But in our jurisdictions, all of us had very good surveillance systems. And of course, comprehensive preparedness plans and regular drills, which many of the jurisdictions in our partners had experienced with either MERS or SARS, enable rapid and effective implementation responses. Of course, important, as we all recognize, is to rapidly ramp up diagnostic testing and contact tracing capacity. And you'll be hearing much more about that in future, which will then enable us to contain large outbreaks. Risk identification and case finding processes in tandem with border controls, quarantine, and case management. Information technology, we know, is very critical in supporting effectiveness surveillance and contact tracing. Then, of course, we need to look at how we broaden screening as possible for travelers coming from outbreak areas. However, we need to how to manage people with issues about isolation is challenging. To build capacity for isolation and quarantine facilities to prepare for outbreaks and review capacity. Physical distancing obviously is the key in part of the control. It causes less disruption to society as opposed to a community lockdown. So the earlier one is able to tackle the issue and control it, the less one needs to go to these community level lockdowns. Of course, sometimes you need to have legislation to ensure compliance. And communication channels, I think we all know, are very important. And cultural considerations, communication of key messages to religious and ethnic minority groups. And importantly, the engagement of community in both the private and non-government sectors to mobilize the available resources is important in control of the outbreak and consistent with the role of stewardship and governance, right? So there are obviously, we understand there are many unintended social economic impacts, and there may be stigma that may arise during the fight, and this will be covered. And priority and implementation of different combinations of measures, depending on the sources of cases and proportion to the stages of the outbreak. So the message here is that we should be more targeted in our control measures, and the more targeted and effective they are, the less likely that one needs to go on the community lockdown, right? And at different stages, in our exit strategies, now that we are moving towards our second study, where we're now looking at relaxation of some of these physical distancing and community quarantine measures, and restoration of socioeconomic activities should be planned on risk assessment, implemented in stages, and reversible when needed. So we'll not be covering this, but this is something that we will be touching on. Right? So I'll cover briefly the Hong Kong. This is the Hong Kong SAR. As you know, it's a special administrative region of China. We have our own laws, but we're still part of China. But we have our own systems of control. And when we looked at the cases, we had our first outbreak, first case in January. Like with most of the jurisdictions, they were imported mainly from the mainland. And then there were good control measures that we started looking at the border control. So the initial emphasis was border controls. But border controls are quite difficult to ramp up. But of course, with more experience, we have looked at where the issues can arise. Of course, one of the problems in many parts of our jurisdictions is that border controls are not just the air traffic, but also the land borders and the sea borders. And so those are areas, and of course, in jurisdictions like Hong Kong, where we're very highly dependent on the mainland, where we depend on our food and water supplies, and there's a lot of cross-border travel. It then becomes quite difficult to control. Of course, in Hong Kong, we have a lot of international traffic, both by sea, land, and air. So there are going to be some leakages. And so you can see that we had some community outbreaks which require some measures. So we were quite early on. We already had good contact tracing. We started looking at some of these physical distancing measures. The Hong Kong population is very alert to these respiratory infections because of our experience with SARS and with H1N1, and they automatically practice physical distancing measures and protect themselves using face masks, which doesn't even need government advice, and they just take it on themselves to do it, and then hand hygiene practices. But of course, then later on, when you see that in the second, when you had a peak of infections in March, this was related to much greater travel from other countries. When the disease has spread, the pandemic, as you know, it was announced at the end towards of March, where the infection then had spread widely in the global community. So our border controls had to be ramped up because initially the emphasis was mainly from the mainland. Of course, then you had infections coming from a lot of our own residents who came back from US, from UK, from other countries, and bring the infection back. So then we started to have more strict controls, and then the social distancing measures were then ramped up. And then when we started controlling and relaxed it, then the population felt quite reassured that the infections are controlled. And then we then had this sudden second surge in June, which is what we'll cover later on in terms of the reasons behind that, but we will not be covering those details today. All right. So in terms of the just two more slides, one is health system stewardship and cross-sectoral collaboration in pandemic responses. So this is the key about the stewardship on governance and leadership role. So Hong Kong, like many of these jurisdictions in our team, when we did research, had the experience of SARS in 2003. And as a result of the SARS, government reviewed all our infection control policies, the laws, etc., and our capacity. And we had an expert committee that reviewed how we dealt with it. And they recommended many recommendations, which were in fact almost practically implemented in Hong Kong. One of which was to set up a separate Center for Health Protection that was responsible for infection control. We also ramped up our infection control facilities. We built over 1,000 infection control beds, and then we had logistics to have PPE stocks to ensure that in future outbreaks, we had at least 3 months of PPE stocks for our health system. We also look at how we can ramp up our surveillance, information, data management, and research and training. So these were our experiences, and we learned from that. So we improved our system, which really helped us control the current outbreak. This is my final slide. So in terms of the experiences, in terms of preparedness plans, we have 3 level response systems of alert, serious, and emergency. And the alerts are triggered by preset criteria. We also have comprehensive preparedness plans and regular drills done by the Department of Health that enables us to ramp up our responses. But obviously, even with the best preparedness plans, when you have an actual outbreak, each outbreak is going to be different. But at least having the experience, you already have the basic infrastructure, but it's got to be modified according to the new context, which is very different. So even when we had good preparedness plans, there's still issues in terms of implementation. Most importantly, the preparedness plans had an infrastructure for interdepartmental, intersectoral coordination. So some of these worked out quite well. There were still problems of implementation. And then we have a very good contact tracing capacity. However, when you have large numbers, it tends to be swamped up. And then we also had to quickly find quarantine facilities, because during SARS, we used some of the holiday homes for quarantine, but of course they were not ideal. But fortunately this time, because learning from SARS, we also then quickly identified that there's some public housing facilities which were ready for use, but did not have residents. So we used those then for quarantine facilities. So I'll stop here and pass it on to the next speaker.
Thank you, Professor Yo, for giving us a brief overview of the lessons learned and also about the situation of Hong Kong. We now want to invite the second speaker, Professor Suman Guan. Professor Guan is the professor and former dean of the School of Public Health of Seoul University. He has been the chief of the Health Sector Group in Asia Development Bank and has been the founding director of the WHO Collaboration Center for Health Systems and Financing. So without further ado, I would like to invite Professor Guan to deliver the talk on responses for COVID, lessons from South Korea.
Okay, thank you. I'm pleased to join this session, and my special thanks to Professor Ike Ye for his leadership for this whole joint research. So let me, I'll very briefly examine the key responses for COVID-19 in Korea. So this is the time trend of the number of confirmed cases of COVID-19 in South Korea. We had a peak of cases. Actually, this is the number of cases per million. So in terms of a real number, we had about 800 new confirmed cases on this very peak day, especially in one area called Daegu, related to a big mega church. And then after that, the number of confirmed cases has been more or less stabilized, and we have another increase in the confirmed cases in mid to late August, and then stabilized. And we have a various series of measures to control and respond. And actually, this shaded line shows the time trend of those some kind of government response stringency measures used in the our world in data. So this is the time trend, and these are the key elements of the response. The first and most important one is the very rapid and flexible response, which was made possible thanks to the preparedness. And the major factor for those high preparedness is the policy learning. From the past experience, we had a quite high number of confirmed cases and mortalities from the Middle East respiratory syndrome in about 5 years ago. And then Korea, the government revised a series of laws for infectious disease and control, which consists of the following. For example, government expanded the then existing Department of Disease Control and expanded it to a Korea Centers for Disease Control, and expanded its personnel and budget, recruitment of and training of epidemiological investigators. And government also introduced the aggressive contact tracing system following the revised laws. Like we used interviews, but if we think that we need more information, the government was allowed to use additional information from credit card, mobile phone location, and CCTVs. And also the new law made it more specific about the coordination of central and local government, and also the importance of testing was realized, and the rapid approval system for test kit was introduced at that time. And the testing, contact tracing and tests are quite, like many other countries. And Korea had some innovations in testing like a drive-through testing and outdoor walk-through testings. And this type of testing facilities avoided the potential infection of facilities and personnel, as well as very rapid testing. And also there are some ICT components. And this is the photos. This type of drive-through testing was introduced as early as late February, early March. And so people just drive the car into the station and they don't have to come out of the car. So this is drive-through, and also walk-through stations was available in many places. And this is the contact tracing system. The main source of information is from interviews by epidemiological investigators, but additional information can be collected through like mobile phone carriers, immigration records services, police, credit card companies, public transit companies, and other government agencies. So the new law allowed the collection of this type of additional information by the government. But still, the major components of the major source of information for contact tracing is the personal interview. And these informations are kind of additional to the personal interview. In terms of governance, I think the multi-sectoral approach was quite effective. So the role of the Ministry of Health was they played a leading role in terms of technical leadership, but the cooperation from other ministries, namely from the Ministry of Finance and Economy and Ministry of Interior and Domestic Security, they also play a very important role. And for this multi-sectoral approach, and also Korea has a national health insurance system covering 100% of citizens, and also covering 100% of all public and private healthcare providers. So this national health insurance system rapidly responded by expanding the benefit packages related to COVID-19 treatment and testing. And NHI also introduced some exemptions and discounts of contribution premium for those heavily affected and vulnerable. And many private hospitals suffer from some cash flow problems, especially at the very early stage of the COVID-19. So this NHI provided an advance payment to support private hospitals. And this is a governance system. There's a local government level response team, and at the central level, there's a Center for Disease Control. But this is another important agency, ministry, like a Ministry of Health and Welfare and Ministry of Interior and Security. And the top, the central disaster and safety countermeasures is chaired by the Prime Minister. Prime Minister in Korea means like a vice president. So essentially, vice president led those whole response system in Korea. And also PP, public-private partnership, was very important. As I mentioned, this national health insurance covers all population, all providers. And in Korea is quite unique, such that more than 90% of Korean hospitals are private. So without relying on these private sector providers in testing and treatment is not sustainable. So these private hospitals played a very important role, especially testing, and also to some extent in the treatment. And also there's a rapid response from the service delivery side, such that many large general hospitals, they introduced a separate paths for respiratory patients from other non-respiratory patients, and telemedicine and prescription without visit was temporarily introduced. But we also have some challenges, because although I mentioned that the public-private partnership worked, but still the majority of the patients, say like 80% of COVID-19 patients were treated in the public hospitals, although public hospitals are less than 10% of all hospitals in Korea, which means that in the preparedness and response, we still, public hospitals is so important. That's the lessons in Korea. So now there's a kind of increased consensus among the public that we need to increase the number of public hospitals. During this, as a lesson from COVID-19. And And also privacy issues. As I showed that we have a very aggressive contact tracing, and this contact tracing is of course based in law, and still the majority of the population, like more than 70–80% of the public, they support this type of contact tracing. But still there's a controversy, right? Because especially from a legal scholars, legal expert, they say, they criticize that as potential privacy issues are not well protected in this contact tracing. And also local government, they disclose the information about the result of the contact tracing. I mean, where this confirmed cases person visited, what kind of public transport they used, which restaurant they visited, where did they shop. But what is the level of the minimum amount of information? And we still achieve the public health goals. So this is a dilemma. And in a democratic society, I think there is we need more discussions. I mean, hopefully after this COVID-19 crisis calms down. I mean, in an emergency situation, I mean, majority of the people, I mean, support this aggressive contact tracing, but it's a big task for the Korean society to discuss more openly about these privacy issues and information disclosure issues in the contact tracing as a response and preparedness for COVID-19. This is it. Thank you.
Okay, thank you, Professor Kwon. Talking about the situation in South Korea, we now move to Singapore. I would like to introduce Professor Vernon Lee. Professor Lee is the Director of Communicable Disease Division at the Ministry of Health, Singapore, and he is also the Associate Professor at the School of Public Health, National University of Singapore. Professor Lee is going to talk about lessons from the pandemic response preparedness in Singapore from SARS to COVID-19. I'll hand over the floor to you, Professor Lee.
Thank you so much, and a very good day to everyone. So I'll be talking a little bit about Singapore's response to COVID-19 and how we actually relied on some of the lessons that we have learned from SARS, pandemic influenza, and also other diseases to strengthen our preparedness response against infectious diseases such as COVID-19. So the principles that we have built over the years essentially are preparedness, to build both the infrastructure and also surge capacity to deal with outbreaks, and also enhancing our capabilities, including laboratory capabilities and also epidemiological and public health workforce. Then we have also built up community surveillance through multiple surveillance methods and also international collaborations, so that through, for example, our links through the IHR focal points and other laboratories and public health institutions, we can share surveillance data. Third, swift and decisive response, both political will and clear direction on how to respond and deal with an impending pandemic, a whole of society effort, and also coordination across government sectors and agencies. And finally, clear communication, both interagency communication and also public health risk communication. So SARS, as you know, was a new disease and in 2003 and was already in Singapore before a response could be mounted. There was a lot of uncertainty when SARS first occurred, and we realized that the impact was actually well beyond just the health sector alone. It was a national crisis, a lot of public concern, and huge economic impact. So what happened during SARS is that a lot of responses were built on the fly. For example, designating a SARS hospital, building up a triage and a surveillance system for a new disease, and also building capabilities, including ramping up infection control practices, development of technology, for example, the thermal scanners, which were one of the first tools developed in Singapore for mass screening of people. And then, of course, interagency collaboration, strengthened contact tracing using workforces from the military and also the police force to augment the health contact tracers. There was also a lot of decisive communications to manage public anxiety and fear. We appointed a lead agency to spearhead communications, had SARS TV channels, school closures in anticipation of the public concern, and also relief package to help organizations and individuals who are affected. We continued this sort of support during H1N1, where we rolled out effective containment through case detection and isolation, contact tracing and quarantine in the initial few cases, and also screening at our borders. We also rolled out public health preparedness clinics, which was something that we put in place as part of our preparedness plans after SARS. And this enabled community-based detection and intervention for a very large number of cases like during the 2009 pandemic, and also subsidized treatment for all Singapore residents. Of course, public education to ask people to look after their own health and the health of others through good hygiene practices, and also enabling a rapid return to normalcy after the pandemic. We also strengthened our frameworks for MERS and also for avian influenza, although we did not have any cases in Singapore. We updated, for example, our disease response framework for calibrated response depending on the nature of the disease, and also focused on preventing importation through many different means and getting the society and also businesses prepared for the next pandemic. So over the years, we have done these things. We revised our national preparedness framework and strengthened inter-ministry cooperation. We have built up our contact tracing centers and trained contact tracers within all of the healthcare institutions and other government agencies. We've also built a new $1 billion National Centers for Infectious Diseases to be a single location where we can treat, manage, and also investigate all cases of a new disease. Public communication, rolling out different platforms on social media, and community measures, strengthening our Infectious Diseases Act as the legal framework, also the public health preparedness clinics, as I've spoken about, and also running a dedicated ambulance service for suspected cases of EIDs. And finally, international measures to continue strengthening bilateral, multilateral agreements to exchange information. So when COVID-19 came, we had all these things in place, but COVID-19 was also very different from the previous diseases. One, there was unprecedented global shutdown, border closures and lockdowns, which is not something that we usually anticipated. There was also mild to severe spectrum of disease, and this has resulted in many difficulties in developing policies and also communications. On one hand, we're saying that we have to consider severe disease in COVID-19. On the other hand, we have to also to look out for pre-symptomatic and also asymptomatic transmission and cases. The infectious period was also challenging because the peak viral shedding was very close to the onset of symptoms with pre-symptomatic, asymptomatic spread, high transmissibility, and also very long drawn. I mean, SARS in Singapore lasted about 3 months, whereas here it was long drawn and with no visible end in sight until a vaccine is available. So our strategy in Singapore very much hinged on 4 main components: prevention of importation of disease and of transmission, detection through case finding and testing capability, providing good care and also research and development, and finally, to contain the spread through enhanced contact tracing and quarantine. So for example, enhanced surveillance system, we developed a suspect case definition. We are currently testing all ARI cases on first presentation, and we also let the doctors have a discretion to test additional cases that they suspect might be due to COVID-19. Our standard surveillance systems for pneumonia in hospitals and also influenza-like illness. And also we roll out screening of target groups, for example, high-risk groups, vulnerable populations, one-off screening to determine the prevalence of COVID-19 in these populations. And thankfully, they have been extremely low. And also active case finding. Every time we find a case, we would test around the case, all of the close contacts, and also persons under quarantine. And every time we identify someone, we would go and find all the close contacts and place them on quarantine. We also tap on information technology to enhance our surveillance efforts. For example, we have this tool called Safe Entry, where everyone who is entering any public places will have to scan in and scan out. That will mean that we would know who has been to all the public places. If there's a COVID case, we can determine other people who may be potentially at risk. We also view, for example, CCTV records. And also we have launched a Bluetooth-based app or token called Trace Together that when the entire population carries this, that will enable us to perform more rapid contact tracing. This app is being increasingly being taken up by the population. I think around about half the population now has either the app or the token, and we hope to increase that to close to 100%. And finally, we also have rolled out apps for persons under quarantine, so we can monitor their health and they can report their health status to us as well. So, for example, the Trace Together tag, they can install this, collect the physical token as I mentioned, and we will use this to enable us to perform more rapid contact tracing. We've also devised a multi-pronged communication strategy through WhatsApp messages that the public can sign on to, and these messages will be pushed, will push COVID information to the public. We have also regular press conferences where we share how we have developed policies through mass media, and also notifications based on the aforementioned safe entry data. If someone has been into a location where a COVID case has been, they can either self-check through a portal, or for higher risk settings, we will push the information through SMS to the individuals. So controlling the outbreak, this is very much a sort of hammer and dance approach, borrowing the Thomas Puyo's approach of sort of keeping cases low and then continuing to sustain that low number of cases by keeping the overall reproductive number below 1. So in terms of a careful calibration of measures, we have gone from an initial stage on the left where we have a baseline set of measures like personal hygiene, stay at home and unwell and so on, all the way to we had a circuit breaker for 2 months because cases were on the rise and we wanted to suppress it. And now when we have reduced cases in Singapore to around practically zero in the community, we want to be able to slowly reopen society and the economy, but achieving that very delicate balance so that we don't open too fast and too much, resulting in high risk of community spread. We're also looking at how we can open up air travel and travel and trade while maintaining the risk to a low enough level to prevent accelerated spread of COVID-19. So, for example, in the gradual reopening, we're trying to see how we can increase the number of people, gathering, going for events, and also, we have recently restarted cruises, and we're going to also have, by the end of this month, a sort of a travel bubble arrangement with Hong Kong, where residents of either country can travel to the other country without any sort of quarantine or any sort of restrictions. So getting ready for the next wave, we think we have to be prepared, but also to stay nimble because there are a lot of changes, a lot of things can occur with COVID-19. Next, we need to collaborate and coordinate across different sectors to harness technology and to also have a clear communications and risk communications sort of framework and messaging. So that's all I have for today. Thank you so much.
Well, thank you, Professor Lee. From Singapore, we'll move to Malaysia, and I want to introduce Professor Chi Wan Ng. Professor Ng is a professor of public health in the Department of Social and Preventive Medicine at the University of Malaya. Her main research interests include health systems, financing, and economics. So, Professor Ng, I'll hand over the floor to you.
Thank you, Prof. Hung, and hello, everyone. Today, I would like to share with you some of Malaysia's experiences in dealing with the COVID-19 pandemic, in the hope that what we went through may help and may be beneficial to other countries. In this presentation, I would like to focus on Malaysia's decision to implement the Restriction of Movement Control Order, or MCO for short, which in one form or another has been in place in the country since 18th of March this year. Malaysia is a country of 32 million people, spread out over 2 land masses, the more densely populated Peninsular Malaysia, and the less densely populated states of Sabah and Sarawak to the north of the island of Borneo. The country's first 3 cases confirmed and detected on the 24th of January this year. They were visitors from China, entered the country via Singapore, our neighbor to the south. We recorded our first 100 cases 46 days after that on the 9th of March. As with the other countries in the region, our previous experiences with SARS and MERS outbreaks led us to strengthen our border control measures, such as health screening of visitors at our international entry points. Malaysians returning home were advised to monitor their health and to seek treatment if symptomatic. In addition, the public were given general health advisory, such as hand washing, cough etiquette, and avoidance of crowded places. Meanwhile, our public health sector went on with its preparedness plan, including heightened surveillance of influenza-like illnesses and severe acute respiratory illnesses, stockpiling of PPEs, improving laboratory testing capabilities, and designating public hospitals for isolation and management of positive cases. In this early phase of the pandemic, our country's strategy of using existing resources within our public health system to trace, test, and isolate confirmed cases seemed to work. Most of our cases then were imported cases or their close contacts. However, Malaysia needed to change a strategy in March, when a large cluster of cases were detected, resulting from a religious gathering of over 10,000 people, including foreign nationals, held in the capital city of Kuala Lumpur over 4 days from 27th February to the 1st of March. By 18th of March, this cluster yielded 513 confirmed cases, or 65% of the total cases in the country. To date, this is one of our largest clusters, with cases over many parts of the country. By the time transmission ended on the 8th of July, there were 3,375 confirmed cases and 34 deaths. The country started a national lockdown on the 18th of March this year, initially slated to last for 2 weeks, but eventually extended to the 3rd of May. People were required to stay indoors, only allowed outdoors if they were to go for essential activities, for instance, seeking healthcare, buying food, groceries. Schools and businesses were closed, except for essential businesses like hospitals, clinics, pharmacies, grocers. International borders were closed to visitors, and returning Malaysians were required to quarantine for 2 weeks, initially at home and later at designated quarantine centers. MCO violators faced fines or prison sentences enforced using legal provisions contained in existing public health laws. In Malaysia, health is under the stewardship of the Ministry of Health, a federal agency. However, we will all appreciate that the prevention and control of COVID-19 and the rehabilitation of the national economy required actions from many agencies outside of the health sector. Malaysia is a federation, but certain powers were retained by the state governments, including religious matters, and in the case of Sabah and Sarawak, immigration control. The direction of the MCO was chartered by the National Security Council, chaired by a senior federal minister, the Senior Minister for Security, with input from the Health Ministry. This allowed for standard restrictions to be applied across states and territories in the country. The MCO restrictions have been gradually relaxed in response to decreasing cases. MCO proper began on the 18th of March. The country entered the next phase, conditional MCO, early May, and recovery MCO from June. Over time, more and more economic sectors were permitted to open. Schools reopened in June, while individuals were only allowed to travel short distances from home for essential activities during MCO. Intra-state travels were allowed during conditional MCO, and interstate travels were allowed during the recovery MCO. Over this time, there had been some localized outbreaks, and these areas, which include villages, apartment blocks, were placed under very strict lockdown, and these are known as the enhanced MCO. Residents living in areas placed under enhanced MCO were not permitted to leave their homes. Food and essentials were delivered to them, and all residents within these areas were required to undergo COVID-19 testing. The different phases of MCO in Malaysia have been credited to have reduced transmission of COVID-19 and to help prevent our healthcare facilities from being overwhelmed. However, this prolonged enforced lockdown had severe adverse economic impact as well as impact on our social lives, and in some cases may have helped deepen existing disparities in society. Schools, colleges, and universities have been essentially closed for most of this year, replaced by virtual teaching, which in many cases disadvantage the poor who may not all have access to computers, and rural children who may have issues with internet access. This contrasts sharply with children from richer societies, richer families, who are mostly schooled in private schools located in urban cities. There are also concerns that cases of domestic violence have increased and that victims may be unable to come out to escape from violent home environments and reach out for help. Needless to say, our economy has suffered with business closures and rising unemployment. In June, Malaysia entered the recovery MCO phase, where there is greater freedom of movement. Schools and most businesses were allowed to reopen. One of the many benefits of MCO has been that it has bought Malaysia precious time for pandemic preparedness. Malaysia has a parallel public-private healthcare system. Thus far, pandemic containment efforts have been mainly borne by the tax-funded public system. One of the strengths of this system has been its public health services against infectious diseases, delivered from district health clinics and offices, where staff are trained to carry out activities such as contact tracing and surveillance for conditions such as TB. These personnel and other resources were quickly deployed to handle the COVID-19 situation. Healthcare provided in the public sector in Malaysia are heavily subsidized, and treatment for most infectious diseases are provided free of charge to citizens. Testing and treatment of COVID-19 are thus free. Free services were also extended to non-citizens to encourage them to come forward for testing and treatment. From the beginning, it has been the policy to admit all confirmed cases to public hospitals or isolation centers. But a large part of the healthcare resources in Malaysia reside not in the public system, but in the private system. During this time, although the public sector continued to manage COVID-19 cases, the private sector has provided assistance in several areas. Private hospitals have taken on the management of some non-COVID patients referred from the public sector to relieve the load on public hospitals. Private hospitals have also loaned equipment such as ventilators to supplement those available in public hospitals. Private laboratories have also assisted in testings of samples. It has now been nearly 8 full months since the movement control order was first implemented in Malaysia. In general, the public has come to accept what we call the new norm avoiding crowds, physical distancing in public places, use of phone-based tracking apps, wearing of face masks, and prohibition of international travels. The MCO put in place in Malaysia in March this year was transitioned to a less restrictive recovery MCO early June. However, there has been a spike of cases nationwide since September as a result of activities related to the state elections held in Sabah. And the conditional MCO and the enhanced MCO have been reinforced in many areas and territories in the country. Though in general, the public is accepting of restrictions to control spread of COVID-19, there is now a growing call for transparency in decision-making and clarity in messages that are being released. It is generally felt that restrictions, if indeed justified, should be imposed focusing on smaller localities of outbreaks rather than imposed on the entire state. With that, thank you.
Thank you, Professor Ng, for sharing with us the different types of MCO in Malaysia. Now, from Malaysia, we move to Japan, and I want to invite Professor Hideki Hashimoto to share with us the community compliance to non-pharmaceutical interventions and the challenges with health governance structure. Professor Hashimoto is the Professor of Public Health at the University of Tokyo, and his research interests cover a wide area, including performance of health systems. So without further ado, may I invite the Professor Hashimoto to share with us your experience in Japan. Professor, please.
Thank you, Professor Han, for this introduction. And I also extend my thank you to the other Professor and the organizers for this session. And it's very honor and a pleasure to me for joining this the specific session to share the lessons for the COVID-19. I think that we already have their very detailed kind of information and policy discussion on the lessons from South Korea and Malaysia and the Singapore case and the Hong Kong case already. And we already found that we have the many common issues for policy reaction against the COVID-19 pandemic in terms of the social distancing and the individual hygiene protections or border control or extensive and intensive the case identification by the extended PCR test examinations altogether. But we already also noticed that how much weight for each strategy strictly depends on each country's situation, such as whether we share the borderline, such as the Malaysia case or Singapore case, or like island case, like the Taiwan and Japan, or there's some demographic their risk structures and their preparedness before this COVID-19 pandemic, such as their former experience with MERS and SARS. In Japan's case, we are isolated island, and we fortunately and unfortunately had not the former experience with SARS and MERS. So this COVID-19 is the real first surprise pandemic that we have to face. And I just share the live kind of presentation of the Ministry of Health the website to show the daily trend of the instance case. As you can see, and I already noticed with the web news in the latest one that in Tokyo Metropolitan here, we marked the largest record of daily instance report for specifically today. We have the nearly 400 just in Metropolitan Tokyo. So this picture shows that in the late March to April, we have this the first surge which started from the border control failure that from the European and the American and the USA are kind of the import cases. And then we have this the summer, the July and August, the second the surge, which is specifically the domestic pandemic. And afterward, we are expecting the third and the largest the surge coming from now on. And with this situation, we want to specifically focus on some unique lessons from Japan, because the other things is already kind of presented from our neighbor countries, and I don't want to repeat this for the time saving. Oops. Oh, I lose my presentation slide, and so I have to present without my slide now. The first thing that I want to, oh, thank you. Maybe I can do again. Thank you. Thank you for arrangement. The first thing I want to share from the Japanese unique case is that the Japan took very unique measure for the social distancing without legislative regulation and the formal lockdown. The government simply announced the emergency status and recommended and asked their people to stay home. And for the restaurants, there is no registered regulation for opening. The government just asks if they follow this the recommendation to shut down, then with some monetary subsidy for compensation. And this is very ostensibly weak measurement to achieve this the effective kind of social distancing and the quarantine across the country. But reality was, as this graph in the right on the lower side shows, this graph shows the estimated crowd number for night bars, dinners, kind of the area in Shinjuku, downtown Tokyo, which is one of the most popular night bar restaurant the city. And as you can see, until the late March, we had the large estimated crowd size. And on the March 27, the Tokyo local government announced the emergency, but without legislative regulation or formal lockdown. And after the 7 days afterward, the central government announced the emergency in 7 largest cities, including Tokyo. And before this government's announcement, this as you can see, the crowd was shrinked down to the almost half by half. So this is very kind of unique. Just asking cooperation makes the effective people's behavioral change in terms of the social distancing and the quarantine. But we don't know exactly why this happens. And there are several kind of the hypotheses, such as the effective and the very impactful kind of information dissemination from the authoritative government, local or central, can make change the people's behavior through the rational decision making. That's one kind of a hypothesis, but I doubt it. The another hypothesis is the very other cultural specific one, such as under this collectivism country, which is the people's the kind of compliance to the social pressure from the prevailing social norm. And this time, it seems like this the social the compliance to the social pressure works very well to introduce this effective the quarantine and the social distancing in Japanese case, but with some social cost because of the social pressure against the open activities. This will result in the social isolation and the over kind of reaction to stay home, which leads to the weakening the functioning among the older people and the stigma against the patients and those who are who kept their open activities for economy. And this may result in the over kind of the downside or downward kind of impact on the economy in Japan's case. So what we want to know is that whether how this are and the social distancing without resistance regulation happen, the mechanism. And I want to say that we are currently conducting the social survey for people's the attitude and the compliance attitude to this kind of social pressure and their actual report of behavior to test this hypothesis. And another one from another unique lesson from Japan was the whether we have the miscommunication between the central government and local government because of this decentralized the political and the governance system in Japanese in Japan. There is some merit in this the decentralized system in terms of each of the local government run their own public health centers to effectively meet their local demand and local situation of the incidents report, identification, and the case tracking. This was the one of the strong kind of vehicle that makes the Japanese successful control over this pandemic. But the pitfall was that because of miscommunication between the central government and the local government, we had a serious problem in terms of the information collection and the data-driven analysis for the policy evaluations. And in these terms, I think the better lessons can be obtained in China and South Korea after the former experience with the SARS and MERS. So again, I want to emphasize that this unique situation across the countries will be the next step for the policy evaluation for each country conditions. Thank you very much.
Thank you, Professor Hashimoto, for sharing with us the situation in Japan. Now we have completed the 5 presentations, but before I open up for Q&A session, I would like to invite Professor Weiping Wang. Professor Wang is the school, Professor of Public Health at the Fudan University, Shanghai, China. He is one of our collaborators in this WHO project. And I would like to invite Professor Wang to ask the first question or say a few comments about his experience. Professor Wang?
Thanks, Professor Huang. Thanks for my colleagues to present the different case on the impacts and effects from different NPIs. I think the experiments from different countries and regions forced to be compared and to present different experiments for the policy making in different countries. My question is for Professor Lee from Singapore. I think Singapore have presented a very good case for a country who have a high risk of importation of COVID-19. So Professor Lee, would you like to elaborate more on risk assessment to guide the open? You said Singapore greatly for the reopen of the system. So can you please to say more about the risk assessment to guide the reopen of for the economics and the system? Is it more empirical or based on the prediction from the mathematical modeling? Thanks.
Yes, Professor Lee.
Hello? Sorry, I was having a bit of connection problems. Not sure if there was I didn't quite hear the question.
Yeah, Professor Lee, my question is, what do you talk more about the risk assessment to guide the reopening of the economics in Singapore? And is it based on more on the empirical or based on projection from mathematical modeling?
Sure. It's actually a bit of both. So what we have developed is actually a tool, we call it the activity budget tool, where we have looked at what are the risks of different activities. For example, activities where you do not wear a mask and there is a lot of talking, singing, for example, and there's a lot of social interactions would come with a much higher risk than, say, activities where people are generally seated without interactions and when their mask is on and they can have some physical distancing. So we have ascribed sort of scores for each of these based on both scientific evidence and some mathematical modeling as well. And we have summed up all these activities, both risks from travel, from opening up of different events, dining, even a number of people that we allow to get into groups, in social groups. And all of this is summed into a score. And the whole idea is to keep the overall reproduction number below 1. The things that will, of course, reduce the overall score or reproduction number will be things like how strong is our contact tracing system, the rollout of these IT technologies, which helps us to reduce the time taken to trace contacts, and also testing. For example, we are doing pilots now to roll out pre-event testing at various venues. And pre-event testing, if let's say even a test is say 80 or 85% sensitive, that will reduce the risk of COVID case entering such an event by at least 80 or 85%. So all of this taken in totality can actually potentially reduce the risk of COVID transmission and allow for the opening up of society and economy. I hope that answers your question. Thank you.
Thank you, Professor Lee. Professor Wang, do you have any further questions? Now, I can not see any questions posted at the Q&A, live Q&A chat room. So I've actually prepared some polls. So I would like to start the first poll. So, and if you see that your right-hand side, there will be a polling, hang on, there was some, okay, I've actually uploaded the poll. So you can actually show your responses. This question is asking for, amongst the following government response measures, which one in your view is the most effective in controlling the pandemic? And I can see that 67% of the people are thinking that physical distancing and personal hygiene measures are the most effective, whereas contact tracing or testing citizens for the virus only takes up 7% of the respondents. Okay, I think I would see whether there's any question. Anyone wants to raise question? If you want to raise a question, please type it in the Q&A box. Now, I have a question for Professor Ng, right? Now, you have mentioned about the PPP with the ventilators being on loan from the private to the public sector. Is there a regular dialogue in place in Malaya, and how easy it is to establish such a collaboration? Because we found in Hong Kong, PPP is often said, but when it is required, it sometimes is quite difficult. Yes, Professor Ng?
Sorry, my mic was muted. Okay. Okay. Yes. When COVID-19 hit Malaysia, I must say that my fellow Malaysians rallied around to help. There were a lot of donations from the private sector for PPE. Even housewives gathered to produce homemade masks and PPE for distribution to healthcare providers, especially in the public sector. There has always been a very close collaboration between the public and private sector in Malaysia. Moreover, quite a few of the private hospitals chains in Malaysia are owned by government-linked companies or partially owned. So the channel for communication has always been open. So in terms of the loan of equipment, it was essentially that of the ventilators, where the hospitals provided a loan ventilators to public hospitals for use. But more on that, it's the how the private hospitals rallied to help, especially our disease control hospital, our main disease control hospital, which was Sungai Buloh Hospital, needed to decant non-COVID cases, and the private sector was there to help out. And also in where I'm working, the University of Malaya Medical Center, cases were decanted to the private hospitals and private clinics in the initial parts of the pandemic. Now, our capacity is quite high, not much better than then. However, we still have a lot of private sector support in many ways. I hope that answers your question.
Thank you, Professor Ng. So I still haven't seen any Q&A in the chat box. So I would like to ask Professor Hideki Hashimoto a question. Now, you have mentioned that in Japan, you does not employ any legislative regulation or penalties in implementing the social distancing measures. You have mentioned that you are studying into why this is so effective. Can you share with us more about what your thinking is right now about how it works in Japan, and probably this will not work in other areas?
Yeah, actually, this is just a current hypothesis. The country I still undergoing on conducting the social survey to measure the people's attitude and the social norms and their actual behaviors. And our kind of research incentive was that if this kind of the people to kind of social psychological characteristics may work for their effective pandemic control, but still it may hurt. It may hurt the economy, and there is the real kind of balance between the health and the economy issue. Can you hear me?
Yes, we can.
Okay. So that's my kind of research motive for this.
Okay, thank you, Professor Hashimoto. Now, Professor Lee mentioned about the apps, right? So let's put up another poll to see how the participants will react to such kind of app. Would you like to install that if it is available? So can you see the question? Have you installed special design apps that will track where you have been to help contact tracing? So the response is overwhelmingly positive. Now, I still haven't seen any. There are two questions, okay. So what is the most effective measure taken by countries in COVID COVID-19 response, were border lockdowns necessary? So anyone want to answer the question? Professor Yeo, want to say some words on that?
All right. I think certainly it's been presented. You need a combination of measures. Of course, the most important is the early surveillance and your case detection and control. So if you're able to do that early, then you don't need to have the lockdowns. Of course, unfortunately, the problem is that in the early stage of the pandemic, one really doesn't know understand completely the behavior of the virus. So obviously there were some issues in some countries, and as Professor and Professor Hideki showed, and also Professor Suman Kwan, there were these very large outbreaks even very early on in those specific countries, where then it became necessary to impose large controls. So people have looked at contact tracing, and the estimates is that if your number of cases exceeds something like about 1,000, then it's going to be quite difficult just to do contact tracing alone in a more traditional way, even with the applications. Of course, obviously, early in the pandemic, not all countries had developed those applications. It was really this was a response to these large numbers that all these innovations occurred. So they never were there before this outbreak. I think certainly if you have a good system of detection and they're able to control these large outbreaks, then you don't need these large lockdowns. So it's really when your system has permitted these number of cases to go into the community that you're then forced to go into lockdowns. And of course, after lockdowns is really then how you get back to normalcy. So you then need to build your surveillance systems during the lockdown. So when you relax the measures, you're then able to prevent another surge, another prevention. In terms of border controls, I think certainly in the early stages, it was necessary because it's really that part of the detection of preventing infections from entering the country. But obviously, as you saw from the country's experiences, when you have land, air, and sea borders, and then you're dependent on your hinterland for a lot of your daily life, it becomes quite challenging. So it's not going to be something that's easy to control. But if you are an isolated island, it's much easier. Like when you look at New Zealand, because they are quite self-sufficient, and it's easy to control those borders. But when you look at in Singapore and Malaysia, in Hong Kong and in the mainland China, because we're so dependent on one another for transfers, then it becomes quite difficult to do the border controls. But still, those are where the cases occur. So it's really how effective you are in able to manage those potential inputs of transmission.
Thank you, Professor Yeo. Any further comments from panelists? I think time is running up to the end of this session. I think the Professor Yeo still have something to say to the audience. I would like to invite Professor Yeo to conclude the session.
Well, I think we had a very rich discussion from the experiences in the Western Pacific region of countries and jurisdictions who had very similar experiences. And I think you can see that although there are certain things that were common, there were also contexts that were different. But the lessons learned are quite similar in terms of you still need to have a good surveillance system, and then case detection, contact tracing. And of course, physical distancing is necessary. In order to avoid lockdowns, if you have effective systems early on, it applies to any jurisdiction, any country. And of course, in many of the developing countries where resources are limited, I think we are already seeing a lot of innovations. And I think the preparedness is something that we need to continue to enhance ourselves, because each epidemic is going to be different. And of course, this epidemic is very unique, as Professor Vernon Lee mentioned. but it's taught us many lessons. I'm sure governments all over the world will now learn from these experiences, and these very rich experiences enable us to strengthen our systems to control this current pandemic and to prevent future pandemics from occurring. Thank you very much to the audience and to our collaborators.
Thank you, Professor Yiu. So that ends the session. Thank you for your participation.
Thank you.
Bye.
Thank you.
Bye-bye.
Bye-bye.